Dr. Chaithanya for the next talk.
Good morning all. I am extremely thankful to Dr. Sasnaman sir and KSOS for giving me this opportunity. I am going to discuss the clinical features of pattern strabismus. As already sir discussed, when a horizontal deviation patient or even an orthophoric patient comes to our OPD, when we measure squint in different gazes, if there is a relative difference in the measurement in up gaze and down gaze, it's suggestive of a pattern strabismus. And when we plot these measurements in a paper from up gaze, midline primary position and down gaze, many times it will resemble many alphabet notations. So the other name is alphabet pattern. Common alphabet patterns like V, A, Y, lambda, X, diamond and arrow. Few points from history. In 1897, Devans noticed V pattern in bilateral superior oblique palsy. Up gaze and down gaze measurements was popularized by Uretz and Savella. A and V pattern was suggested by Uretz. And coming to the pathogenesis, Knapp proposed oblique muscle dysfunction being the most common etiology. Coming to the clinical features, when a patient with either exotropia or esotropia come to our OPD, and when we measure the deviation in all gazes, and especially when there is a difference, gross difference in up gaze and down gaze. If for an esotropic patient, if there is a relative convergence in down gaze compared to the up gaze, suggestive of a V esotropia. And same way, if for an exotropic patient, if relative divergence in up gaze compared to down gaze, suggestive of an V pattern exotropia. When will become this V pattern significant? The difference between up gaze and down gaze measurement, if more than or equal to 15 prism diopters, this V pattern is significant for the further management. Usually associated with inferior oblique overaction or superior oblique palsy or other malformations. Same way for the A pattern, for an exotropic patient, if there is relative divergence in the down gaze, is suggestive of A pattern exotropia, and if relative convergence in the up gaze, suggestive of A pattern esotropia. When is this A pattern significant? If the difference between both up gaze and down gaze measurement more than or equal to 10 prism diopters, this A pattern is significant. Usually associated with superior oblique overaction or infantile strabismus, craniofacial malformation, Down syndrome or meningomyelocele. The other common pattern is Y pattern. Here the horizontal deviation remains same from down gaze up to the midline, and there is a relative divergence in the up gaze. Usually seen in bilateral inferior oblique overaction, Devans or Brown syndrome. Lambda pattern is the opposite of the Y pattern. Relative divergence happens in the down gaze, usually seen in overacting superior obliques or bilateral underacting inferior rectus, probably after a large recession surgery or slip muscle after surgery. X pattern is relative divergence both in up gaze and down gaze, usually seen with type 3 DRS or long-standing exo cases. Other patterns are diamond and arrow. Also, we should see the pseudo patterns. Pseudo V esotropia is seen in accommodative esotropia with uncorrected refractive error. And intermittent divergent squint can manifest as pseudo exotropia. Sometimes hydrocephalus or plagiocephaly manifests pseudo A pattern. Coming to the pathogenesis, the cause usually lies between peripheral mechanism and the central. Central cause is between the loss of fusion or abnormal fusion due to abnormal torsion mechanism. Peripheral cause lies between the three group of muscles and the pulleys and orbital anomalies. Oblique muscle dysfunction being the most common theory proposed by Knapp. Here the abduction being the tertiary action of oblique muscle is the culprit. What happens when the primary or secondary overaction of inferior oblique leading to increased abduction in elevation? For example, when inferior oblique overact, superior oblique will underact along with the elevation and abduction, there will be a relative divergence in the up gaze. Horizontal muscle dysfunction was another theory proposed. Here the imbalance of horizontal muscle forces was added as cause of pattern strabismus, but electromyographic study do not support this hypothesis. Cyclovertical muscle dysfunction is a less accepted theory. Muscle pulley dysfunction is another common factor. Here the extraocular muscle pulley heterotopy can lead on to vertical incommitance. Anomalies of muscle pulley can result in slippage of the ocular muscle during globe rotation, suggested by Demar et al. Clark et al. Suggest by even a small mislocation of less than 2 mm of the pulleys is significant. Orbital anomalies, craniofacial abnormalities, hydrocephalus, craniofacial syndromes all can contribute to the pattern strabismus. Neural factors, the theory lies between the loss of fusion with abnormal torsion. All these theories proposed by Miller and Guyton, Piper et al. All these relays between the loss of fusion and torsion mechanism. For example, in an excyclotropic patient, superior rectus will act as an elevator along with an abductor, and inferior rectus will act as an adductor also. Horizontal muscles, medial rectus will act as a partial elevator and lateral rectus will act as a partial depressor. This will contribute to a V pattern in a excyclotorsion. Coming to the clinical presentation. The clinical presentation varies based on the type of the strabismus and the amount of squint. Patient can present to you with ocular deviation or intermittent transient diplopia due to loss of fusion in certain cases, or sometimes asthenopic symptoms in cases of a pre-presbyopic group, especially in the down gaze, or sometimes compensatory head postures. Compensatory head postures can be chin up or chin down based on different patterns. How we will evaluate a pattern strabismus patient? Definitely we need to do a full refraction. Then the deviation should be measured in all 9 gazes, and the deviation in primary, up gaze and down gaze should be clearly measured, especially with a full correction of the refractive errors and for distance. Near to, it is always advised to do for distance measurement because to avoid the accommodation in the near measurement. 25-degree up gaze and 35-degree down gaze is advised. Also see whether there is any over elevation or over depression in adduction to rule out the obliques overaction or underaction. Binocular function should be seen and the ocular torsion should be ruled out by a dilated indirect ophthalmoscopic examination and orbital imaging in selected cases. What is the clinical importance of pattern strabismus? For all horizontal strabismus, we need to detect and measure whether a pattern is there. If so, we should look for what is the etiology, because it will help to modify the surgical procedure and to plan the surgery ahead. Sometimes for larger deviation, we may need to go for a 2-step procedure. Thank you.
So, thank you, Chaithanya. So, Chaithanya was telling us about the clinical features